The Atlantic General Hospital and the Center for Joint Surgery present a seminar on young and in pain, joint replacement for the young.
My name's Tom Beck. I'm an orthopedic surgeon. I've been practicing here. It'll be 6 years on April 1st. Before that, I practiced 3.5 years in Philadelphia. I did all my medical school training, residency, and then I did a fellowship at the University of Pennsylvania in hip and knee replacement. And I'm now the director of the Joint Center at Atlantic General Hospital and the chief of surgery. This is not true. Joint replacements don't last only 10 years. We have done a lot in materials and a lot in design that allow these to last longer. We don't know how long because we've only been putting in these newer things for 10 or 15 years, but the early results are very good. A joint replacement cannot be redone if it wears out. That's false. We have many options for redoing. We have bone grafting techniques. We have revision stems, revision prosthesis. We have bags and bags of toys that we can do. And I've done recently, I think it's about a year ago, there was a lady I did, she had her knee done 8 times, and I did the 8th one. And she hasn't been back in a year and a half, so that's a good sign. Patients cannot return to normal activities after a joint replacement. Up until, it was discouraged for people to return to normal activities because we're trying to make things last as long as possible. If you buy a new set of tires on your car, if you drive your car 100 miles a week, the tires are going to last longer than if you drive 1,000 miles a week. So what we did was we discouraged people from doing their normal activities. With these newer things that we're going to talk about today, we think that people are going to be able to return to normal activities. I still discourage people with a knee replacement from running, but people who have a hip resurfacing, I would tell them they could run at some point. So, so most of these things are not really true anymore. My thinking, not so conventional. Again, there's no age restriction on joint replacement. The disability, pain, and the patient understanding of what they're going through is the main things that guide whether I do a joint replacement on somebody. The youngest person I ever did a joint replacement on was during my fellowship. She was 12 years old. She had juvenile rheumatoid arthritis. Her choice was to live her teen years in a wheelchair or to have a joint replacement, walk, go to school every day, go to her father-daughter dance, go to the prom, and her family made an informed decision and did that. And she went on with her life for as long as I know for the next 10 years. It was 10 years ago or 12 years ago. And so in that particular situation, we gave that person a new lease on life. And instead of being in a wheelchair as a teen, she's going to live a normal life. She'll deal with the consequences later, revision surgeries down the line, but she was disabled and she had significant pain, so we went forward. The newer components have the potential to last up to 30 years. We're talking about different bearings. We're talking about ceramic. We're talking about special polished metal. We're going to talk about a special metal that is transformed into a ceramic. So when we use these things in a lab and we test them, they last much longer. We can cycle them in the lab, and we can show how much wear debris is generated and how long they'll last. And they'll last much longer than the conventional things that we've used for 30 years. Patients can return to most normal activities. Bone-preserving surgeries are now available, and we'll talk about that. And you can obtain good results with revision surgery. Non-surgical treatments. As a surgeon, maybe this doesn't sound like I'm doing myself a disservice by talking about this, but almost everyone that comes to my office, with a few exceptions, we always try to do conservative treatment first. And activities modification. Doc, it hurts when I run. Okay, well, how about if you bike instead of running? How about if you swim instead of running? Can you still get, the same endorphin rush? Can you still, be happy doing that? And if you can, then you can put off these surgical interventions for a longer period of time. Non-steroidal anti-inflammatory medicines like Motrin, Naprosyn, Celebrex, these are all medications that help with pain and inflammation and can allow people to return to normal activities. Glucosamine and chondroitin sulfate is a naturally occurring element. It's sort of like a vitamin pill for arthritis. It really doesn't have any side effects as long as you're not taking blood thinners or you're pregnant or you have diabetes. But in those people that take it, 50% feel better. So I tell people to take it, see what happens. If you feel better, great. If you don't, well, it's not going to work for you. Corticosteroids, these are cortisone injections. People with knee arthritis, hip arthritis, shoulder arthritis almost always get a cortisone injection from me before they ever get a surgery, with some exceptions. Synvisc and Hyalgan, there are some medications that we'll talk about too. Activities modification, again, flares are activity related. It hurts when I run, and the next 2 days I suffer for it. So you try to avoid repetitive weight-bearing exercise. Weight loss is very important. Just 10 or 15 pounds of weight loss can make a tremendous amount of difference in the pain you have in your knee or your ankle or your hip. had a patient who followed with me for a year. The day I met him, he weighed 308 pounds. A year later, he still weighed 308 pounds. And I was giving cortisone injections every 3 months. So I finally knew he wasn't going to lose weight, and I said, look, come back and see me in 3 more months, and if you want to, we'll do your knee replacement. He came back in 3 months, and he was fine. I said, your knee doesn't hurt? No, my knee doesn't hurt anymore. Why? I lost 35 pounds. So that amount of weight in that person was enough to take his knee arthritis, the symptoms he had away. Assisted devices for ambulation, such as canes and braces, can also be helpful. Anti-inflammatories, again, highly effective treatment for arthritis. They decrease inflammation and pain. The traditional anti-inflammatories like Motrin, Naprosyn, and Indocin have kidney and stomach side effects. Therefore, they came out with the COX-2 inhibitors, such as Celebrex, Mobic, and the one you've heard about, Vioxx, that got taken off the market. They're no more effective than the regular anti-inflammatories. However, they have less side effects from a renal and GI standpoint. The cardiac safety has come into question, but Celebrex has been very, very well tested and actually is the only anti-inflammatory that is indicated to use if you're taking aspirin for your heart. The corticosteroids, these are cortisone injections used for many years. They're very safe if they're used judiciously, not the way Joe Namath used them, before practice, before the game, at halftime, and before I went out on Monday night. But if they're used my guide is every 3 months, they're very effective. There's few systemic side effects. You can get a transient increase in pain called a steroid flare, which is usually treated with ice, and you can also get a transient increase in blood sugar if you're diabetic. Again, 4 in 1 joint per year. General rule. Synvisc and Hyalgan, these are brand names of hyaluronic acid. They're naturally occurring proteins in the knee joint fluid. What happened is, many years ago, these have been out for maybe 25, 30 years. In Belgium was where it was invented. They analyzed people whose joint fluid had no arthritis and people who had arthritis, and they found out that this protein was missing from arthritic knees. So they found out also that if you ground up rooster combs, you had this protein sitting there. So they said, well, let's shoot it in the knees and see what happens. And lo and behold, people felt better. Only about 50% of the people, but they did feel better. It does not reverse arthritis. It does not grow cartilage again. It's just symptomatic relief. If it does work for you, if you're one of the 50% that it works for, it can last 6 months to a year. So it's a good alternative to steroid injections.